Good afternoon, ladies and gentlemen. Today we should speak about injury of the vision organ. To tell the truth, I would like to say you that this is a very important topic. Injury of the eye usually affect young people, and injury is one greatest of the greatest cause of blindness and visual disability. I recommend you to listen these lectures carefully because this information will help you in your future work. If you would like to be ophthalmologist, for example, and if you won't be would like to be ophthalmologist, and if you will be GP or other doctors, the knowing of the basic things how to diagnose and how to management injury of the eye is very important for all doctors. Injury of the eye and its surrounding tissues is the most common cause of attendance at an eye hospital emergency department. Outcomes of ocular traumas may be the minor or severe with a lot of vision or even the eye. And just to think about mm, these numbers, more than half of the million blinding injuries occur every year. So half of the million people every year mm, become blind because of the eye injuries. Ocular and orbit injuries in the majority of cases occur following sporting, domestic, or motor vehicle accidents. Games and sport are the most common reason of ocular and orbital traumas in children. You see, classification of the ocular trauma, we divided all traumas on local, when just eye and ocular adnexa are affected, or and associated when had also affected face injury, multiply injury like polytrauma. All over the world, where we speak about eye trauma, we use Birmingham eye trauma terminology system. We use this classification. It's rather easy, maybe not so easy, but it helps us to make correct diagnosis and the correct management of the trauma. So, all eye injury we divide it on closed globe and open globe. Closed globe contusion and lamella laceration. Look on this picture. As for the open globe, we divide it on laceration and rupture. For example, in a severe contusion, maybe the rupture of the eyeball. As for the laceration, we divided these these traumas on penetrating, when uh, one um, one part of the eyeball is affected intraocularly, ocular foreign body, and perforating, when we see two holes. As for penetrating, one hole. As for perforating, two holes. Again, on this picture, you see the Birmingham Eye Trauma Terminology System classification, and we will speak about all these traumas. We start from the closed globe injury. The eye wall does not have a full thickness wound. Either there is no corneal or scleral wound at all, contusion, or it's only partial thickness, lamellar laceration. No, for example, for the closed globe injury, extraocular foreign body, for example, cornea, foreign body, abrasion, burns, chemical injuries, closed globe injury with lamellar laceration. As for the cornea foreign body, it's rather often situation, and a lot of the patients come to emergency ophthalmological department with such traumas. We should, if we see um, such situation, we should immediately remove this foreign body, or the patient in future can have um, severe keratitis or even corneal ulcer. Open globe injury, full thickness wound of the cornea of a sclera, maybe the rupture or laceration. Here you see example with the open globe injuries, the injury of the cornea, and here you see the two iris in this wound, very severe trauma. Uh, okay, speak a bit open globe injury rupture. Rupture is a full thickness wound of the eyeball caused by a blunt object. The impact results in momentary increase of the intraocular pressure. The eyeball gives way at its weakness point, at the impact site or elsewhere. Example, an old cataract um, wound, uh, even though the impact occurred elsewhere. The actual wound is produced by an inside-out mechanism. Okay, more often we see open globe injuries, laceration. Full thickness wound of the eyeball usually caused by a sharp object, like needle, knife, scissors, or flying metallic foreign bodies. The wound occurs at the impact site by an outside-in mechanism. As I have already mentioned, all lacerations we can divide on penetrating injury, uh, intraocular foreign body, and perforating injury. As for penetrating injury, we see single laceration of the eye wall, and no exit wound has occurred. So just one wound. No intraocular foreign body, it's clear. Uh, when we find intraocular foreign body, it's of course open globe injury. And perforated injury, when we see two wound, two full thickness laceration, we see entrance and exit. Okay, on this picture you see examples. Okay, penetrating injury, just one full thickness wound. intraocular foreign body, and perforating injuries. You can see entrance and exit. Okay, let's speak about closed globe injury. Clinical manifestation. Let's start from the orbit. Yeah? Blowout fracture, orbital hematoma, carotid cavernous fistula, and also foreign bodies. On this picture, you can see examples of mm, fractures of the orbit. Medial, lateral, blow fracture of orbital floor. Eyelids. When we see the contusion of the eyelids, we can see enormous swelling and um, edematosis, hematoma, avulsion of the lower lid, and foreign body. I would like to say that I hope you remember that eyelids have very good blood supply. That's why hematoma appear very often of the eyelids, but it's also very quickly disappeared. Let's go further deeper. You see conjunctiva. On this picture, you can see conjunctiva hemorrhage. Here you see conjunctival laceration and you see conjunctival foreign bodies. It's also closed globe injuries. Cornea. Uh, I have already mentioned that maybe abrasion, stromal edema of the cornea, partial rupture, blood stain of the cornea when blood enter into the cornea, and cornea foreign body here. Look on this picture. You can see the corneal foreign body. On this picture, you again see the corneal foreign body in a microscope. On this picture, you can see how we remove foreign body. It's an outpatient procedure. We make this in an emergency department. I have already mentioned that it's absolutely necessary to remove corneal foreign body. Usually we put anesthetic drops like alkaline, for example, and then remove foreign body. Cornea is very sensitive, but cornea reacts very good on local anesthetic. And when you put alkaline, for example, you can remove foreign body without any difficulties. Okay, go deeper, go further. We decided changes in cornea, then go deeper, anterior chamber. Mm, Rather often in a closed globe injury, we can see hyphema or changes of the deepness of anterior chamber. On these examples, you see on this picture, you can see different examples of hyphema. Mm, As for anterior uvea, pathology of the iris, We can see iridodialis. Yeah. We can see tear of the iris sphincter, iridoschesis, and angle recession. Okay, let's go further, deeper in the structure of the eye. Then after iris, lens. We can see Wilson ring. We can see cataract. What is cataract? Any opacity of the lens. And we can see subluxation or luxation of the lens, so we can see the changes in the lens position. Lens can move forward or in a vitreous body. Vitreous body after the lens, I hope you remember anatomy. We can see posterior vitreous detachment. It's not so serious situation, but in severe cases, in severe contusion, we can see the hemorrhage in the vitreous. Uh, you know that blood is not transparent, and that's why hemorrhage in vitreous rather serious situation because patient complains on bad vision. Retina, the most important part of the eye, it's a sensitive part of the eye, and we can see different changes. Of course, hemorrhages. You can see Berlin's edema, macular edema, and you can see even retinal dialysis or even retinal detachment. Optic nerve. When we examine the fundus of the eye, we can see the disc of the optic nerve, and we can see traumatic optic neuropathy like edema of the optic nerve, hemorrhages, and in very severe traumas, we can see avulsion of the optic nerve. Okay, another example of open close injury are burns. Burns are the very important cause of visual disability. Mm, the most important burns, chemical, thermal, and UV burns. As for the chemical burns, we can divide all burns on alkaline and acid. Chemical burns are more severe, and severity of the eye burns depends on the agent, its concentration, and duration of exposure. Usually, we say that alkaline burns is severe than acid burns because alkaline usually spreads and tissue more quickly than acid. Alkaline makes colliquative necrosis and acid coagulating necrosis. I hope you remember this from the course of pathophysiology. Uh, Clinical features of the eye burn, I think it's easy to predict. Usually, it's very great pain. The patient can't open the eye, tearing, blepharospasm, decrease of or loss of vision. You can, during examination, see the edema, redness of the eyelids, of the conjunctiva, the severity uh, of eye burn. Usually, we measure by Roper Hall classification. According to this classification, we have four grades of the burns. First grade, we see epithelial damage, no limbal ischemia, and such burns usually have good prognosis. Grade second, hazy cornea, iris detail visible, and limbal ischemia less than 1/3, and all uh, the prognosis is also good. Grade third, cornea is opaque, iris we can see, mm, and limbal ischemia near half, and visual prognosis usually not so good. And grade 4, um, very severe, um, very severe burn, uh, totally opaque cornea, limbal ischemia more than half of the limbus, and prognosis usually poor. But on this picture you see examples of um, examples of burns. This is the first grade. This is the second. You can see limbal ischemia, and this is the third grade. Uh, well, let's speak about treatment of chemical burns, the most important first aid. If you will be ophthalmologist or not, you should know how to help the people with the chemical burns. Very important prophylactic of shock, local and systemic um, anesthetic, analgesic and anesthetic. If we see the pieces of chemical structure, we should remove these pieces, and then we should irrigate and we should wash the eye as much as possible uh, to remove um, the pathological structures, pathological agent very carefully. Usually we use water or saline solution near 5 minutes. Then we should put antiseptic and antibiotic in eye, and also um, give to the patient systemic antibacterial medicines. We should prescribe tetanus prophylactic, ointment, uh, antibacterial or antibiotic ointment, and the skin usually treated with different sprays like panthenol, different antibacterial ointment. Very severe complications maybe after chemical burns. Usually these are corneal opacity, symblepharon, recurrent corneal ulceration, complicated cataract, and secondary glaucoma. Look, the total opaque cornea. This is also against cornea. We see that conjunctiva close the cornea defects. Here we see that very severe, after very severe burn, we have totally closed eyelids. Thermal injuries, usually caused by fire or hot fluids. Usually the mm, the conjunctiva and eyelids suffer more severe from this thermal burn than cornea and more deep structure. The Usually the first aid is same like in the case of the chemical burns, but there is no necessary to wash the eye so long time. I think it's necessary to wash just to decrease the temperature, but not so long as in the case of chemical burns. And all other procedure uh, are the same like in the case of chemical burn. So we should prescribe analgesic, we should prescribe antibiotic, local and systemic, we should prescribe tetanus prophylactic, and of course we should send the patient in an ophthalmological department. Ultraviolet burns usually etiology of the situation, welding without proper eye protection, exposure to high altitude sunlight, and sunlight reflected off snow when skiing, and sometimes we also can see the patient or a nurse who work in the hospital and use correct oil lamp. Symptoms usually very typical. The process, the symptoms usually appear after 6 or 8 hours, and the patient complains on pain, bad vision, feeling of foreign body, lacrimation, so the typical corneal syndrome. Examination. During examination we can see redness of the eye, we can see corneal edema, and superficial puncture keratitis. Uh, Treatment. The blinded patient should be instructed that the symptoms will resolve completely under the treatment with antibiotic ointment within 1 2 days. Mm, and usually we use intramuscular analgesic and can put anesthetic drop in conjunctival cavity. The prognosis usually good, and the patient should be instructed to use special glasses when he works with the UV devices. So we have already discussed close globe injury. Now we should speak about penetrating injuries. On this picture, you can see examples of severe penetration injuries when we see the full laceration of the cornea. So, absolute signs of penetrating wound: gaping wound in the eye, Protrusion of the eye bone contents outward. For example, here you see protrusion of the iris and the presence of intraocular foreign body. In some cases, when we see the small injuries, for example, in cornea, we can't say exactly is it penetrating or not. We use fluorescein, which help us to say is it penetrating eye wound or not. Not. We see that this is penetrating eye wound. I would like to show you some examples of penetrating eye wound. Look, this is a severe cornea injury, iris, eye wound, scleral eye wound. This is a intraocular foreign body. This is intraocular foreign body in the fundus of the eye. I would like to tell you that all foreign body which are situated in eyeball have to be removed. If we say foreign body in eye, we will receive the severe complication like different metalloses. We will speak about these complications a bit later. And how we diagnose the foreign body in eye. Of course, we can use slit lamp. It's a biomicroscope. You will see such devices during our practical classes. We can use X-ray. It's one of the most important method. And ultra and we can see um, ultrasonography. Also, a very informative method. What should we do if we see the penetrative wound of the cornea? First aid, it's very important. We can uh, we can, uh, at first we should make the patient medicine for the shock prophylactics like local and systemic analgesics. We should remember of the tetanus prophylactic and about infection prophylactic. So we should put local antibiotic and systemic antibiotic, and we should make binocular bandage. So we should close both eyes. You should ask me why, if one eye is affected, we should close both eyes. It's important because when one eye is moving, other eye also moves. So we should close both eyes to prevent additional trauma. The first aid in a case of penetrative wound of the sclera is the same like in a case of penetrating wound of the cornea, but we also should add the medicine which help us to prophylact hemorrhages. In a special ophthalmological department, of course, we should make the surgical operation to to prevent difficult complication, and the purpose, of course, of our treatment to save eye's anatomical structure, and if it's possible to save visual function. In very severe cases, when we see the crushing of the eye wound, of the eyeball, we make enucleation of the eye. What are indications for enucleation of the wounded eye? Primary enucleation is performed in the case of crushing of the eyeball, and later eye is enucleated in the case of recurrent sympathetic inflammation of the healthy eye, painful secondary glaucoma, and atrophy of the eyeball. Let's speak about complication of the perforative and penetrating eye injuries. Of course, it's infection, maybe purulent iridocyclitis, endophthalmitis, panophthalmitis. I would like to say that even small trauma, penetrating trauma, with a good visual function may be the cause after 1-2 days of severe endophthalmitis. Oh, it's a pity I saw several such cases. Uh, when we leave intraocular foreign body in eye, we can see complication like metallosis or siderosis and halcosis. In later time, we can see sympathetic ophthalmitis, traumatic cataract, secondary glaucoma, and retinal detachment. Let's pick some words about metallosis. Halcosis appear when the copper foreign body uh, is in eye. We see cornea in cornea Kaiser-Fisher ring, a golden brown ring at the level of the cement membrane. We can see anterior sunflower cataract. We can see green discoloration of the iris, so our iris becomes green, and we can see yellow retinal flages. Uh, Siderosis appear when we don't remove ferrous foreign body. Siderosis may develop as early as a few days or as late as several years after injury. Clinical features include redness, mm, heterochromia of the iris, secondary glaucoma, anterior capsular cataract, also reddish ferrous deposits, and we can see pigment dispersion and retinal detachment on the retina. Some words about very severe complication of the penetrating eye wound, sympathetic ophthalmitis. This is a condition in which granulomatosis uveitis attacks the second eye after the injury of the eye. So this is inflammation of the healthy, normal eye. And you can imagine how difficult and how serious situation. We have on one eye uh, with a bad vision after the trauma, and after 2-3 months or even years, another healthy eyes becomes mm, becomes ill, becomes sick. Usually the time of interval between injury and development of sympathetic ophthalmia 3-8 weeks. In rare cases, 5 days or even 60 years after penetrated trauma. And the cause this um, of this situation of this process antigen antibody interaction. Nowadays, thank goodness, we rarely see such situation. It's the prophylactic of this situation as a good surgical treatment um, of the trauma using steroids and other modern medicines. And clinical picture of sympathetic ophthalmitis. As for injured eye, low-grade plastic uveitis, which include ciliary congestion, lacrimation, and tenderness. And second eye, sympathizing eye, normal eye, which was normal. We see acute plastic erythritis. Treatment of sympathetic inflammation is very difficult. We should make enucleation of the injured eye. We should use anti-inflammatory, serious, aggressive anti-inflammatory treatment like using the topical and systemic steroid, in severe cases immunosuppressive drugs, and no, of course, atropine to prevent synechnias and other plastic processes. I would like to thank you for your attention. I hope you will receive some necessary information for you how to manage the eye injuries, because early diagnostic and first aid are the most important things for good visual prognosis in eye traumas. Hope to see you in our practical classes. Good luck and thank you for your attention.